The next thing we're going to talk about is treating the elderly, and I can relate to this. My definition of what it means to be an elder changes every year I get a little bit older. Let's see. And I want to focus on late life depression, okay? Now, some people have made the claim that depression, major depression, actually occurs less in elders than it does in the general adult population, but this is very misleading and complicated, okay? Now, complication number one is that 9% of people who have major depression kill themselves, okay? And people that have chronic or recurrent depression on average are living about 9 years less primarily because of cardiovascular disease, because of high cortisol levels. So by the time you get to be 65, there's going to be a fair number of people who've had major depression who have died. Everybody with me on that? Okay. But the other thing is this, and that is if you look at here, this is the young old and this is the old. Okay, you look at major depression, 3%. Now, this is yearly prevalence rate. Yearly prevalence rate in adults is 10%. You say, oh, that's way below that. Although there's 13% that have so-called subsyndromal depression. There's a big problem with DSM-4, and that is they didn't include any elders in the field trials. And what they did is they said, well, depression is depression. You know, you can use the same criteria for older people, and it's wrong because there are similar symptoms, but there are some symptoms that are just different in older people. And so many of these people that have so-called subsyndromal depressions, instead of having what you have to have 5 out of 9, you know, to make major depression, they've got 4. So they're, guess what, subsyndromal. So in DSM-5, presumably there's going to be information in there that helps you diagnose more accurately children with depression and elders with depression because it's not all the same. So the presence of substantial depression with elders actually is quite high. Okay. All right. Ageism. This is a big deal, and you know, I think we get acculturated to this very early in life. You know, go to any drugstore and look in the gift card section, greeting card section, and over the hill cards and all these jokes about older people, and everybody laughs, you know, about that. But from early in life, you know, there's this pervasive sense that when you get beyond a certain age, you know, you're useless. You can't contribute to society. You're sexless. You know, diminished cognitive capacity, on and on and on, and it's horrible, and it translates into some really bad problems, I think, in the medical care system. And one of those is that the medical profession, and I know this is a generalization, but I think it's also true, when people get pretty old, they're going to be less aggressive about really trying to treat diseases across the board because, well, you know what, they're not going to live very long anyway, kind of mentality. And many people that end up in nursing homes have significant psychiatric problems. They may have, lots of them have dementias, okay, but lots of them have other kinds of treatable psychiatric disorders, especially depression. And yet the vast majority of these people are cared for not by psychiatrists, but they are cared for, if you want to use that term, by primary care doctors that kind of make a visit once or twice a week. And a lot of the treatment that goes on in those kind of facilities has nothing to do really with reducing suffering as much as it has to do with behavioral control. You get people, for instance, have Alzheimer's disease and they may get aggressive or scream or do different things like this. And the goal really a lot of times is just to calm them down so they don't bother other people, including the staff. So this is a huge issue that really infiltrates into most areas of medicine. Inadequate screening in primary care. Most primary care doctors, more than half their clients, more than half their patients are over the age of 65. And the reason for that is because, obviously, you get past the age of 60, 65, people start having more diseases. So they have huge numbers of people that are coming in that are elders, but oftentimes they're not screened appropriately for depression. In part, it's because they don't have enough time. In fact, there was one study, I don't think I have a slide here, but one study where they found that over the age of 80, even somebody who's significantly depressed, they were rarely asked about if they were feeling suicidal. Significantly less often was that question brought up than people that were under the age of 60 who had major depression. And when the doctors were asked about why didn't you ask about that, what they said was, this is the most common response, we just don't have enough time, and I had to deal with these medical issues, and then my 15 minutes is up. Okay. Another thing that clouds the picture is with depression is that a lot of depressive symptoms are seen with a number of medical conditions. You get fatigue, weight loss, poor concentration, psychomotor retardation. This may be associated with any number of physical ailments. So it becomes much more of a challenge to do differential diagnosis and really tease out what is depression versus what is some kind of a medical problem. Okay. So I want to talk for a few minutes about cardinal features of late life depression. And this is probably rightly at the top of the list, and it's disengagement. and it's stopping doing things that make life meaningful. Pulling away. Don't answer the telephone. Don't call people up, say, let's get together. Stop going to church. People pulling away, okay? And again, ageism comes on the scene where a lot of people say, well, yeah, but a lot of old folks do that. No. Older people that are not depressed don't do this. They tend to keep more active, okay? Anxiety and irritability is seen much more common than sadness. And this is like with kids. Remember, I talked a week or two ago about this, that many people go unrecognized because they're not weepy and they don't have depressive affect and that sort of thing. And so there's some guy, and the main manifestation, mood change, he's walking around the house cursing and slamming doors and stuff. And a lot of people say, oh, he's just a grouchy old guy, but he may have major depression. And by the way, did this get all the way around? Sign-in sheet? Okay. So these things are really important to look at, pessimism and feelings of worthlessness. And here, this is not meant to be a manifestation of ageism, but probably a reflection of just something about the culture that many of older people nowadays, that are older now, grew up in a culture where they were very disinclined to talk about personal emotional issues, okay? And so this older group, compared to younger adults, are less likely to voice their worries and complaints about feeling worthless or sad or what have you, which means rather than sitting there and waiting for somebody to say, we have to actively inquire about this kind of stuff. And then PMS, persistently miserable syndrome, okay, happens in old age. Dementia and depression. Okay, now this gets really complicated for several reasons. Okay, first off, it's looking more and more like the earliest sign of Alzheimer's disease is depression, even before memory problems start to emerge. The hippocampus has a lot to do with affect regulation and, of course, the ability to take in new information and learn. It's one of the first parts, it's actually the first part of the brain that starts to really disintegrate with Alzheimer's disease. And so it's not unusual that a person who maybe has never been depressed during their lifetime, 1 to 3 years before starting to show cognitive manifestations, and with Alzheimer's it would start off with memory problems, that may be the earliest sign that they are moving towards Alzheimer's disease.